Sound check, sound check. Hi, folks. Professor Culliford here. Let's go ahead and do a screen share. We have one more lecture to do for the cardiopulmonary anatomy and physiology course. Yesterday, I recorded the final exam review for you. I hope that you find that helpful. Definitely focus on the review sheet. In a course like this, there's so much information that it could be overwhelming, but that's why we do a review sheet. We do just the things you really need to know. And if you will practice on that, listen to that video a couple times, I think you'll be in good shape for the final exam. It does need to be complete by Thursday, and I'm recording this on Tuesday. There's your leading causes of death in the U.S. Heart disease, cancer, no surprise. Accidents, I'm a little surprised, but accidents are third. Chronic lower respiratory, that's COPD pretty much, and pulmonary fibrosis. Stroke, Alzheimer's, diabetes, influenza, pneumonia, and then kidney problems, and then intentional self-harm. That's tragic that the 10th leading cause of death is intentional. Uh, but there we go. Heart disease, clearly, the single biggest problem that we have, and that is largely diet and lifestyle. Let's just be completely honest about that. High blood pressure, cholesterol, obesity, diabetes, all those are very hard on the heart. Cellular degeneration of heart muscle cells just happens as we get older. You can slow that down. You can affect, how long your heart stays healthy, but eventually, time. What does they say? Time is undefeated. Time is undefeated. Yeah. So there we go. Primary structural change in the heart is thickening of the inner walls caused by development of fibrotic tissue and fat deposits. So again, clearly related to diet and lifestyle. Yeah. The thickness of the left ventricle increases by about 25% by the age of 80, and that happens pretty much no matter what we do. Fibrotic changes, calcification of the valves, everything gets stiffer and less effective. Cardiac output goes down, the ejection fraction goes down. So, sorry to give you a negative view of the aging process, but it's just reality, right? Cardiac output goes down about 1% per year after age 20. When you're 20, your heart's as good as it's going to be. And then it starts downhill at that point. Yeah. We also see changes in the SA node as our patients get older, and as we get older, so that it does not function as well. That's why so many of them have atrial fibrillation, because the SA node is not working as well as it used to. Vascular system also changes with time. The blood vessels become less distensible. The blood pressure generally goes up, and corresponding slight increase in thickening of the blood vessels throughout the body. It's just reality. That's why so many of our patients at the hospital are in their 60s, 70s, and 80s. Yeah. Aging affects the respiratory system. We have to know the patient's age in order to determine what their normal pulmonary function would be. And the lungs get stiffer, they lose volume and lose flow rates with time. So, it's just a process that we go through. Yeah, there is a thing called senile emphysema, and I think that's pretty interesting. This is deterioration of the alveoli. We've talked about those air sacs in the lungs, and they do, actually deteriorate. Even if the patient never smoked, even if they've never, had a high dust or pollution environment, it happens. Yep. We see this affected in the four lung volumes, the inspiratory reserve volume, tidal volume, expiratory reserve volume, vital capacity. Um, TLC, actually, total lung capacity, stays relatively constant, but the RV, that's the trapped air, increases in almost all patients with time so that they have less room to breathe with each breath. There's more trapped air as time goes by. Yeah. The FEV1 goes down, vital capacity goes down, minute volume, peak flow, pretty much just happens. Diffusion, the carbon monoxide diffusion capacity, which is a test you'll learn how to do once your clinicals are underway. Um, It goes down about 20% through a lifetime, beginning at age 20. Again, when you're 20, your lungs are the best they're going to be, and so same with your heart. This is a little look at the normal changes that take place. I'm going to try to make that a little bigger for you so that you can maybe read it a little better. But you can see all these things that change with time, and we can have some impact on that, but not a lot, to be honest. COPD, persistent airflow limitation that is progressive and is associated with inflammatory response of the airways. About 16 million uh, patients in the United States with COPD. And that is a low number because we know that there is emphysema out there that never gets properly diagnosed. Yeah. Here's a number that you definitely need for your boards: the presence of a post-bronchodilator FEV1 to FVC ratio. That's how quick can the patient exhale, um, and that is less than 70% to confirm a diagnosis of COPD. That's also what qualifies patients for pulmonary rehab, by the way. Non-pharmacologic treatment of COPD, smoking cessation, pulmonary rehab has been a wonderful addition to the care of these patients. Oxygen therapy, many patients at home on oxygen now. And then we use various medications like the short-acting beta agonists, the long-acting beta agonists, the short-acting anticholinergics, methylxanthines, corticosteroids. Look at all of them, and the phosphodiesterase inhibitors. You'll learn about all those in pharmacology class. I wouldn't expect you to, get all that in just this first course. Individual treatment plan for COPD is important. What we're doing is trying to improve their activities of daily living and their quality of life. That's what we're trying to do. Left to their own devices, I hate to say it, but COPD patients will find a recliner chair and sit there with their oxygen on and only get up to go to the kitchen or the bathroom. That's a simple truth. But in pulmonary rehab, we break that cycle and we insist that they get up. We give them extra oxygen so it's possible. We monitor them so that they know that they're safe. But we insist that they get moving, and it helps. Clubbing, that's the physical change in the fingernails, widening and increased roundness of the nails. And we think that this is due to chronic low oxygen. Chronic low oxygen. So we see that in COPD, cystic fibrosis, pulmonary fibrosis as well. Some of those diseases that are long-term and low oxygen diseases. That gives you the shape right there. Here's a little trick you can do. It's kind of fun. Put your thumbs together, nail to nail, and you should be able to see a little diamond shape between your thumbs. If you cannot see that diamond, then that probably is an indication of clubbing. You can see that the nail is sort of hooved up. I'm going to use that description, and consequently, you lose the diamond between the thumbs. Cystic fibrosis is the genetic disease. You have to have both parents carrying a recessive trait before the child can have cystic fibrosis. About 30,000 patients across the country. It is a disease entirely of European descent. This mutation took place thousands of years ago, we think, in Europe. So only people who came from that part of the world will have this trait. If they're, I think the question was asked in class, and it was a good one about mixed race individuals who have, two or more different races in their background. Those people could have cystic fibrosis, but there had to be at least one European ancestor back there that was the source of this trait. Terrible disease, but we do treat it better than we used to. It's a lack of a key enzyme, and because of that, all the mucus is extremely thick, extremely thick. And that's throughout the body, not just the lungs. Sweat chloride test. You need to know this. The sweat chloride test of at least 60 makes the diagnosis of cystic fibrosis. Sweat chloride. The mom will say, "This baby is salty. They kiss the baby and they notice that the baby has a different kind of a saltiness of the skin, and that leads to the test. And then we can find out if maybe they have cystic fibrosis. Yeah. 60 is the key number you need to know on that. That does show up on board exams. Treatment, optimize lung function, address the genetic mutation. It is a disease which probably is going to be an example of gene therapy. But until we have that, what we really have to do is keep the mucus moving. That is the most important thing in cystic fibrosis. You may have seen a VEST therapy unit. VEST therapy was invented for cystic fibrosis, and it has done a remarkable job of improving their lung function. Yeah. Corrector therapies, various medications are being taken to identify the specific mutation in the CFTR gene. That might be worth remembering. The CFTR gene, that's the one that causes the problem in cystic fibrosis. Again, both parents must be carriers of the CF trait in order for a child to have cystic fibrosis. Pulmonary fibrosis is stiffening and scarring of the lungs, and this happens usually in a relationship to some kind of an exposure, dust exposure, fungus exposure, coal dust, silica dust, just about any kind of dust that can get into your lungs. Asbestos, another example. And if we don't know exactly why the patient has pulmonary fibrosis, then we call it idiopathic. One of my professors said, we're idiots about it because we do not know what caused it in this particular patient. So idiopathic pulmonary fibrosis, we have a tremendous amount of that in the Western United States, and certainly that's because of the dust that we inhale in so many of our jobs and just lives. Yeah. Pulmonary fibrosis cannot be reversed, but we can improve the patient's quality of life and their activities of daily living, and that is through pulmonary rehab. I think I mentioned in class that that's what I actually do now when I see patients is I do pulmonary rehab. You get to a point, and I'm definitely there, where you can't run the floors at the hospital. Typically, respiratory therapists go about 3 to 4 miles per shift, and that would be really hard for me at this point. But I can see my patients in pulmonary rehab, and I can keep up with it quite well. Lung cancer, the good news on lung cancer is we're now understanding the specific mutations that cause the lung cancer, and we're treating those specific lung cancers. Now, the one that you want to not hear the doctor say in the diagnosis is small cell. That is by far the worst lung cancer. It's also known as oat cell, small cell or oat cell. Non-small cell has a much better outcome. Small cell is the bad one. That does show up on boards also. Yeah. So let's see. Smoking, of course, is a key factor in lung cancer. On the non-small cell disease, lung cancer, we have several types. Adenocarcinoma, that's about 40% of lung cancers. Squamous cell, about 25%, and large cell. All of those are much less invasive, much less aggressive than small cell. Again, small cell, oat cell is the bad one. There's a staging system that we use to determine how far the cancer has spread. And a big tool we have is the PET scan to identify just where the cancer has reached. PET scan is measuring the metabolic activity of different tissues in the body, and you can actually see the cancer light up on the PET scan. This is some detail on the lung cancer staging system. I would not expect you to learn all of this in your very first course, but we will surely go over it when we do the disease course together. Treatment for lung cancer, radiation, chemotherapy, targeted treatments such as immunotherapy and surgery all have a role, and it's usually a combination of those that winds up helping the patient. More people survive lung cancer today. I think partly that's because we're detecting it sooner, and partly because we have more specific treatments for the specific mutation that the patient has. Pneumonia. Pneumonia is still the number one reason people get admitted to hospitals in America. And it's lower respiratory tract infection that can be either viral or bacterial. We used to say more bacterial, but then COVID came along and kind of changed all that. COVID was really a viral pneumonia, is what that amounted to. Yeah. We have all these different bugs that can cause pneumonia. I won't try to make you memorize that list here in this very first course. Community-acquired pneumonia is mostly what we see. However, pneumonia can be acquired in a nursing home setting or a hospital setting, can even happen to a patient who's on a ventilator. So these pneumonias are very important to prevent, to reduce, to not spread pneumonia from patient to patient in the hospital. That's an important thing you're going to be involved in. Healthcare associated pneumonia, that is a key problem that we have. Patients get admitted to the hospital for something else, but then they pick up a pneumonia while they're there. So we are working really hard to not let that happen. You'll see a lot of strategies going on at the hospital. Pardon my voice here. Diagnosis of pneumonia is mostly by chest x-ray, but there will also be a blood test, and we're especially interested in the white count. The white blood cell count, WBC count, is normally 5,000 to 10,000. And in a big bacterial pneumonia, that could be as high as 20,000 or even 25,000. Yeah. So normal WBC count is 5 to 10,000, but it goes up in bacterial infection. Treatment, bronchial hygiene, antibiotics, anti-inflammatories, oxygen, and a ventilator if necessary. Most pneumonias do not require a ventilator, but some do. Antimicrobial stewardship, that's making the best use of our antibiotics and trying not to overuse them. I think probably we have a history in U.S. medicine of overusing antibiotics, even when there was no bacterial infection at all. It was a virus. So, there's no way to treat a virus with an antibiotic. But we're trying to be smarter about that and thereby avoid multi-drug resistant organisms. There was a year, I think we're going to talk about tuberculosis here pretty soon, but there was a year that we had no new TB cases in America. I think it was 1981, but it is back. Tuberculosis is back, and it's a worse infection now. That organism, tuberculosis, Mycobacterium tuberculosis, has mutated and has become much harder to kill. Yeah. Coronavirus, well, you know about that. We lived through it, the pandemic together. March 12th of 2020 is where the official outbreak was, announced, a global pandemic. And respiratory therapists had a huge role in getting patients through that. Oh my gosh, it was rough. I got to tell you, what we had is patients in small hospitals where they did not even have full-time respiratory therapy. And then we just had to somehow make it work because there was nowhere to transfer those patients to. The big hospitals were already full and on divert status. So, wow. I kind of wonder, how we got through it, but we did get through it. Lost a lot of lives. I want you to know something. You're probably going to hear somebody say, well, it's not safe to work in a hospital because of these pandemics. It turns out that very few respiratory therapists died of COVID. More nurses died of COVID than respiratory therapists. So as long as we're taking proper precautions, it's just not something you should worry about. Yeah. I took care of hundreds of COVID patients myself, and I never even tested positive. Okay, let's see here. What else do you need? This is talking more about different coronaviruses that have happened through the years. An interesting thing happened. Patients in my age group actually did better in recovering from COVID. And we think that's because we probably had another coronavirus somewhere along the lines. Might have been swine flu in the 1970s. Some of the worst COVID cases were young people in their 30s who had no what would we say, resistance, no resistance at all. They had no antibody to coronavirus. So, that's been kind of an interesting phenomenon. And some of them had permanent damage to their lungs or hearts. Yeah. Barometric pressure, this talks about altitude. And it's very interesting how the altitude changes. But I want to make sure you're aware of something. The oxygen percentage, the oxygen percentage is the same all over the world. It's 21%. So some sneaky person writing a board exam might ask you, what is the oxygen percentage at the top of Mount Kilimanjaro? Well, guess what? It's 21%, just like everywhere else. What's different is the barometer, the barometric pressure. The higher you go, the lower the barometer, and because of that, less oxygen. I don't know if you've ever been at a high altitude location like Breckenridge, Colorado, let's just say, or top of Pikes Peak. But the air is really thin up there, which means the barometer is low, but it's still 21% oxygen. All right. Let's see here. As we go up in altitude, the oxygen level, the PaO2, decreases. And as long as we stay above 60, that's kind of an important number. As long as we stay above 60, the patient's okay because that means they're 90% saturated with oxygen. But if it goes below 60, if it gets to 50 or 40, the patient is going to be in real trouble quick. So that's an important number to keep track of. And that's why a lot of people, when they go to high altitude, have to use oxygen up there. Yeah. Let's see here. Cardiac function also changes at high altitude. When the final ascent was made to Mount Kilimanjaro, the top, the thing that made that possible was oxygen and BiPAP. Those climbers were actually using oxygen and BiPAP the night before their final ascent, and that's what gave them the oxygen to make it to the top. They didn't stay up there very long because their oxygen, the air is so thin up there, but it's still 21% oxygen. You can actually wind up with a high altitude pulmonary edema. I think that's interesting. That's where fluid goes into the little air sacs, the alveoli, because the barometer is so low, sometimes called chronic mountain sickness. Acute mountain sickness, also happens when people go to high altitude suddenly. Um, there are some things that can be done if you know you're going to altitude, some medications like dexamethasone to, reduce the effect. But there is still this effect which happens. High altitude cerebral edema can actually be dangerous. You can get swelling of the brain, particularly if there's a rapid ascent without time to, compensate. Exactly why that happens, we're not quite sure. And why the pulmonary edema happens, probably it has to do with a difference in pressure between the capillaries and the alveoli so that fluid actually leaks out into the alveoli. High altitude retinopathy, they can actually get damage to the retina of the eye if the patient is at too high of an altitude for too long. Yeah. So it's pretty clear human beings were intended to live somewhere close to sea level. We don't do well at high altitude. We really don't. Ultraviolet keratitis is a injury to the eye, which can happen. Treatment includes avoiding ultraviolet radiation, cooling compresses, anti-inflammatories. We really don't get involved with that very much. Chronic mountain sickness is something that patients deal with when they're at high altitude for a long time. And this can actually progress to right-sided heart failure or left-sided heart failure. Yeah. Almost done. You guys have done an excellent job in this class, and I just want to thank you for being so focused and getting all this stuff done, especially those case studies. You did excellent work on those case studies. Sleep disordered breathing, we have two different kind of problems there. You have obstructive sleep apnea and you have central sleep apnea. Some patients have a combination of both. Obstructive sleep apnea is really a blockage of the airway which can be pretty well treated with CPAP. Central sleep apnea is where the signal does not come down from the brain, so the patient is not even trying to breathe. That one has to be treated with a BiPAP or maybe even a ventilator. Obstructive sleep apnea, we see it so much, especially, you might pay attention to this, in patients with a neck size greater than 18 and a half. Patients with a neck size greater than 18 and a half, and largely that's male, but some female as well. These apnea periods can last up to 10 seconds or longer with no breathing. So a sleep lab, fascinating place, and I hope you get to see a sleep study during your training. I would say you ought to make sure that happens. Yeah. You might wind up a sleep disorder specialist. It could happen. Yeah. Apnea is defined as at least 10 seconds of not breathing. And hypopnea is a little breath that has an airflow less than 50% of a normal breath. There we go. CPAP, probably, BiPAP also, the primary way that we treat that. Study of anatomy and physiology provides a foundation for safe, effective medical care. The things you learned in this course will come back again and again and again as you go through your training and as you conduct your clinicals. So, my pleasure to work with you. I believe you guys have a week off next week before the next semester starts. So, I hope you enjoy that and wishing you success on the final exam.